Yes, we are conducting a series of projects at the Simpson Center on ways of improving the end-of-life experience for patients, doctors, and families. So this comprises about a couple of dozen projects along the patient's journey, which is from the time they're diagnosed as having a terminal illness until after death. And for one of the examples is we developed the Crystal tool, which is a checklist based on objective clinical parameters to determine the risk of death to the person during a hospital admission and in the subsequent 3 months. Another project is, for example, a systematic review looking at the extent of non-beneficial treatments applied or administered to elderly people who are seeking emergency assistance in hospitals at the time of, in the last few months of life. Another project is the impact of advanced care documentation on the clinicians' willingness to engage in the end-of-life conversation with people who haven't been told they're dying. Another project is we have consulted consumers, that is, patients who are terminally ill, their families, or relatives of people who have died bad deaths in hospital, to find out about their priorities at the end of life, their preferences, and how satisfied they are with the care they received. So these are sort of a range of examples. We have many other projects we have involved clinical decision makers, policy makers, consumers, and many other researchers, nurses, and doctors in telling us about where the gaps are and how things can be improved. With some of the findings of our research, for example, we did a systematic review on decision aids, and we showed that, first of all, there are very few instruments out there to assist patients and families in making decisions at the end of life on what sort of treatment to have. And some of the instruments have deficiencies, such as they lack numeric prognostic information about the harms and benefits of each of the treatment options. So that is really not very helpful for patients because they will not be making a genuine decision on something as important as whether to have a treatment or not. And they also lack step-to-step information about how to make the decision which route to take. And more importantly, they lack the information the patient values, what matters to them, quality or quantity of life. And that is a big gap that needs to be filled because genuine decision-making cannot happen until those gaps are filled. And the other results that are important to us was the validation of the Crystal tool in 14 hospitals across 5 countries, which showed that the accuracy of the tool is over 80%, which we're very satisfied with because we're not dictating treatment as a result of this accuracy. We're enhancing the prognostic certainty for doctors so that they can initiate the end-of-life conversation. Some of the challenges that we have encountered in our research are the difficulty in diagnosing the dying patient. It is very easy when it's in the last few days or hours of life, but it's not as easy when it's a few months before the death. The other problem is the difficulties of measuring frailty in emergency departments, and frailty is one of the most significant predictors of death. There is also the difficulty in attracting further funding because this topic is not sexy and it's not splitting genes or developing new technologies or medications. So a lot of funding bodies are not interested in enabling us to continue the research. Getting published has been another difficulty because there is a lot of politics around us revealing that the end-of-life care is costing a lot, but the outcomes are still poor. So a lot of medical journals are reluctant to accept our publications. And there is also the criticism from the public that we are using a medicalized approach and that we should involve the consumers more in designing our projects, and we are actually doing that through the establishment of consumer advisory groups. Yeah, some of the reasons that have led to the practice of non-beneficial treatment in hospitals are the prognostic uncertainty when doctors are not sure about how much longer the patient has to live, the high social expectation of immortality because the technology is there and people want to use it to be kept alive, and the lack of a conversation between patients and families about their preferences for type of treatment and place of death before the crisis arrives. So other reasons could be the families refuse to accept poor prognosis, or they're in conflict with the members of the family about what to do or what not to do, and doctors' personal beliefs or fear of litigation. The benefits of not administering non-beneficial treatments are multiple. For example, first of all, they would prevent suffering to patients. They would prevent families having false hope about the possibility of recovery of a person. They would help families to go through a healthy grieving process after the death because they knew what to expect. They would prevent staff turnovers because a lot of doctors and nurses are dissatisfied with the fact that they have to administer these treatments knowing that they are futile, and they will lower the problem of unsustainable cost of care for the health system. We think the topic is getting a lot of attention from media and from health services because, first of all, governments and health services have realized that the population is aging, and the estimates are that the 65-year-olds and above age group will double by 2050. So that is associated with an increase in demand for services, hospital admissions, ICU surgeries. And because also the technology will improve and the expectation will enhance. And the doctors and nurses are realizing we need to do something about this catering for this demand. There's also a revolution happening out there with people changing their mind about whether the topic of death is a taboo, but whether they want to be part of the decision of where to die and how to die well. And so there is a change, a social change out there where people are more assertive and more knowledgeable. There is a lot of information on the internet, so people want to be part of that decision. And the media, I'm not sure why we have been so well received by the media, but we're very grateful for it because they're presenting the case that we are actually empowering people to make the most important choice of their life. And we're not just dictating treatment or telling them whether to go for aggressive treatment or comfort care. Well, I feel I'm very pleased and grateful for the invitation to share our findings with the people in the UK. We're very humbled by the media attention and the fact that this media attention led to this invitation. I don't only want to share the findings, but also the lessons learned and the difficulties we had, the obstacles we encountered in the process, because I think it applies everywhere in the world. I'm looking forward to starting some collaborations with some of the academics and maybe running some workshops with students to sort of come together about how to tackle this big problem that is of universal proportions. And also, I want to learn from you guys because there is a lot of information here in Australia about how progressive the health system is in the UK, how many outreach programs and new initiatives are happening, and guidelines about improving the end-of-life experience. So we want to really find out from you what works and how we can bring that knowledge back to Australia to implement it or adopt it or adapt it here.